Hello dear friends, this is a case of a 60-year-old male patient who presented with severe abdominal pain, vomiting, distended and tender abdomen, periumbilical pain and tenderness in the left iliac fossa. The WCCs were raised 16.8 and the query was diverticular disease. This is the topogram and this is the CT scan. I will scroll down the images a couple of times to have a look and make your own impression. Of course, we will discuss the findings. So let's start from the query to confirm or exclude diverticulitis. We can see the rectum in this region, and as we track the large bowel upwards, we can see some free fluid in the pelvis. There are some traces of fluid on the other side, on the left side as well, here. If we go a little further up, we can see some additional free fluid in the abdomen, reactive fluid. And let's go back. Here is the sigmoid colon. It is normal. There are no mural changes. Here is the sigmoid colon. We go little up, and here is the descending colon. Let's scroll it and tracking up. Okay, so the whole large bowel looks normal. There is no evidence of colitis or diverticulitis or other acute pathology in the large bowel. So now let's have a look to the small bowel. The small bowel loops here are a little bit matted, difficult to be separated from each other. There is a degree of fecalization. Some of the small bowel loops show some prominence but no significant dilatation, and there is an impression of mild wall thickening edema, particularly in this region. And there is also blurring of the mesenteric fat. I will zoom in to have a closer look, and there is an impression that the mesenteric vasculature is more prominent. There are some reactive changes. This is the mesenteric vasculature, mesenteric fat blurring, free fluid in the abdomen, some dilation of the small bowel loop. Okay, and these findings are highly suggestive of inflammatory changes in the small bowel. In this region is the terminal ileum. We can easily identify it from this fat tissue surrounding the terminal ileum in the cecum. And the terminal ileum looks not so bad. There is no definite evidence of some pathology in this region. This small bowel loop shows further wall thickening and edema comparing to the rest of the small bowel. There is some accumulation of fluid in the left iliac fossa. Probably this could explain the pain in the left iliac fossa for some reason, and accumulation of fluid in the lower pelvis in this region as well. We have intermittent dilatation of the small bowel, small air fluid levels here and there. Here is a stenotic point, but not evidence, so there is no evidence of any mechanical obstruction anyway. So the findings are suggestive of ongoing inflammatory and probably maybe infectious changes in the small bowel and mesenteric reaction with mesenteric fat stranding, prominent mesenteric vasculature. Here some slightly reactive lymph nodes, mesenteric lymph nodes in this region. The differential diagnosis in cases like this includes enteritis, ileitis, or even underlying inflammatory bowel disease. There is no evidence of ischemic changes, there is no intramural gas, there is no gas in the portal venous and mesenteric venous system, so there is no evidence of ischemic changes. Small stone in the gallbladder, by the way. Dear friends, thank you for watching. If you like my videos, you can subscribe to my channel so you will be notified the next time I will upload an interesting case in radiology. Thank you and see you the next time.